There are issues that are common to all young adults with the cancer, such as the potential for infertility because of their cancer treatment.
I didn't think about being a father at 17. I didn't think about being a cancer patient either. If I thought about it, if I researched it then, I don't know what my view would have been. But that was the last thing on my mind.
As someone who is approaching the age of where I need to start thinking about having children or where that's going to happen in my life, there's always a concern about that, especially as a woman. What's going to happen to my baby-making abilities? Are my eggs going to be any good later? What is this going to do to the rest of my body? I was fortunate enough that the kind of procedures that I had are supposed to have minimal effects on my ability to have children. But it's still something that could happen. And the truth is, I won't know until I try.
I do kind of wish there was more information on like the fertility aspect and that kind of thing, because I got sort of differing stories from different people. And at the end of the day, I just decided to be safe about it and go ahead and, you know, bank some sperm just in case, because I do want to have kids.
In our own institution at Seattle Children's, we've been trying to create best practices for ways that we can encourage people to preserve their fertility prior to the start of their cancer therapy. So get teenage and young adult males to go sperm bank on a routine basis if they're interested in that, and getting selected populations of teen and young adult female cancer patients to bank usually oocytes in our pediatric population. This is now an option for, again, for some cancers. And in older populations of young adults, embryo cryopreservation, freezing down embryos for later use, is also a possibility.
Current research questions and policy concerns.
When people will become infertile from cancer treatments, how do you predict the ovarian reserve that's present in a woman after her cancer therapy is done, and thus define how early she might have menopause if she does have menopause early.
So one of the policies that we're working on is one around insurance reform, specifically to address the needs of those who could potentially have their fertility impaired as a result of their cancer treatment. We know that most insurance plans right now do not cover fertility preservation services, and you know, iatrogenic infertility is something that should be covered, just as breast reconstruction is covered for women who have to have a mastectomy. If we know that the treatment is going to potentially cause people to lose their fertility, I think we have an obligation to ensure that their fertility is preserved through, you know, evidence-based technologies that we know work, and it should be reimbursed. Because the risk is, if someone takes the decision as to whether or not their fertility is going to be impaired and makes a less efficacious treatment decision based on that reality, they're putting themselves at risk. And so we want people to be able to make the best decisions for themselves and not have to make the choice, should I take the treatment that's recommended and risk my fertility being preserved, or preserve my fertility and don't take the recommended treatment. That's a terrible choice to have to make, and it's unnecessary when it's based on economic or insurance issues.